or a disease coming from the bone marrow are the people who are most susceptible to the neutropenic fever, with bone marrow malignancies like leukemias, sitting of lymphomas inside, aplastic anemias, drug-induced pancytopenias, immunological pancytopenias where the bone marrow is empty. These are the patients who are most vulnerable. We will review in brief the Infectious Disease Society of America's guidelines for use of antimicrobial agents in neutropenic patients with cancer and discuss various clinical manifestations and approach to their management. So the susceptibility factors in patients with hematologic malignancies are umpteen, like severe prolonged neutropenia, the extended use of implanted IV devices, frequent blood product administration, which make these patients immunocompromised. You must know that blood transfusion is a situation where repeated use of blood transfusion leads to the patient immunosuppressed. More frequent antibiotic use with development of more drug-resistant flora, clinically significant mucositis, which is the drug effect in various chemotherapy because of various chemotherapeutic agents, and asplenia may be functional or anatomic, all lead to the deficiencies and susceptibility to infections. You can see here an example of a mucositis because of chemotherapy, and the drug is shown on the side bottle, that is the cytarabine, and high-dose cytarabine therapy leads to mucositis, which invites the bacteria to gain entry into the mucosa through the brakes and gain entry into the bloodstream, leading to septicemia and even to the increase in the mortality in such situations. Radiation therapy also predisposes to bacteremia and fungemia. So what is the historical basis for approaching patients with neutropenia? It was long before. In 1996, it was shown by Bodie at NIH Bethesda, who showed the quantitative relationship between circulating leukocytes and infections in patients with acute leukemias. And he did show that the number of neutrophils are an important figure, and those are associated with increased risk of infection. The lesser the neutrophils are, the increased possibility of infection is there. And at the same time, the longer the duration of fever, in a patient of neutropenia, the more likely that the patient would develop fever and septicemia and is amenable to mortality. What are the febrile neutropenic syndromes? First is fever. We have to analyze what is fever, and a single oral temperature of more than 101 or a temperature of more than 100.4 lasting for more than 1 hour. And neutropenia, as such, normal neutrophil count is 1,500, but a count of less than 500 is considered a very grave situation for invitation of fever, and a count of less than 1,000 with predicted to be less than 500 again is another situation. And a combination of fever in these patients leads to the febrile neutropenic syndrome. And these are the practice guidelines based on which our lecture is based, which are periodically issued by the Infectious Disease Society of America, and this is the latest guideline of 2010 update by Infectious Disease Society. And how we approach these patients, we have to look carefully to very, very small parts of the body. You have to see the patient's oral cavity, see pharynx, lower esophagus, listen to the lungs, see the perineum. Perineum is a very important area because of its moistness, closeness, crampedness. This is the area of entry of bacteria, fundus. Anal also should be inspected properly, but you should not do an PR examination. Try to avoid it as much as possible in patients of neutropenic fever. The most important point in neutropenic patients that any type of intervention which can bring in bacteria from outside to inside should be avoided, because that can land up the patient in septicemia. Skin, you check for bone marrow inspiration sites, vascular catheter sites, tissue around nails, etc. And the important point to be noted here is that in neutropenic fever or in neutropenic infections, because of the absence of neutrophils, normal signs of inflammations will be absent. So what you will get as an abscess, what you will get as an accumulation of pus-filled cavity will not be possibly there. And this is obvious from this table, which is showing that the patients with less than 100 neutrophils per cubic millimeter are showing fever and bacteremia as the only manifestation of infection, while as patients with more than 1,000 neutrophils per millimeter square, you can see that you can have exudate, purulent sputum in addition to fever and bacteremia. So lack of localization of infection and absence of signs of inflammation are classical of neutropenic fever. Even in patients who is not keeping well, a sudden fall of blood pressure can be also considered as an indication of a neutropenic sepsis. And then you have to assess these patients to approach them properly for management, and that is based on a score called as Multinational Association for Supportive Care in Cancer, MASCC score. which actually gives good points or higher points if there are no symptoms, if there is no fall of blood pressure, if there is no active or chronic lung infection, if it is not a case of solid tumor, no dehydration, and a patient who is on outpatient basis or a young patient less than 60 years, all point favor towards a higher score which indicates the lowest risk of neutropenic sepsis. This is important score because based on this only we approach these patients, how we are going to manage them. And that is how we manage that higher the score, the highest theoretical score is 26, and a score of more than 21 is considered as a low risk. And if the patient is having neutropenia, patient is having fever, but he belongs to the category of score of 21, then you can even possibly put the patient on oral antibiotics. And the combination best described is ciprofloxacin plus augmentin. However, you might be required, depending on the situation, to add the monotherapy, but the antibiotics should be of extraordinarily broad spectrum, which can include piperacillin, tazobactam, cefepime, ceftazidime, imipenem, and meropenem. High risk are the patients where the score is less than 21, and then probably you need to add drugs like aminoglycoside and or vancomycin, and we will see their indications subsequently. So if you approach these patients and decide to use the antibiotics, what antibiotics should be used? We are not interested in antibiotics which are lower antibiotics, maybe something, something like an ampicillin or another sort of a penicillin. We want antibiotics which must cover the deadliest organisms like Pseudomonas. And we have to have antibiotics of the third or the fourth generation series, and cefepime, ceftazidime, carbapenems, piperacillin, tazobactam, plus minus aminoglycosides are the empirical antibiotics. Let me tell you that in these patients, even if you try to do the blood culture, urine culture, in more than 50% of the patients, you are not going to get any growth. So the treatment in these patients have to be based on empirism. You have to go empirical administration with antibiotics because you have to treat the patient. The bacteria may or may not be identified. You may not get a growth, but you have to treat, and the treatment is such that it should cover almost all types of the bacteria which could be possibly there in that patient. And the most important thing I would like to reiterate here is that the antibiotics dosage should be the maximum possible allowable doses. You don't have to start something like ceftazidime 1 gram BD. If it is allowed to go for 2 gram TDS, you must go for the highest possible dose in the upfront setting itself. You don't have too much time. It's a medical emergency. Febrile neutropenia patients are indeed to be fought and treated on war footing only. So, if you have got a high-risk patient, probably you need to add drugs like vancomycin and aminoglycoside, and then what are the indications of addition of vancomycin? I know that most of the time our practices, we usually give the patient meropenem, vancomycin as a combination to start with, but that is not usually required. There are certain finalities which you can go into where you can add vancomycin in clinically suspected serious catheter-related infections, when there is a colonization of penicillin or cephalosporin resistance MRSA bacteria, when the blood cultures are growing gram-positive bacteria before final identification and susceptibility, hypotension or other evidence of cardiovascular impairment, intensive chemotherapy producing extensive mucosal disease as I shown you earlier, like high-dose cytarabine, previous fluoroquinolone prophylaxis, and soft tissue infections. Why am I unable to get forward? Can you help someone? Can someone help me? Okay. So, yeah. So now you initiate the patient on an antibiotic as I described earlier. Most of the time, the patient would be afebrile in the first 3 to 5 days. But then you have to decide how long I have to continue the antibiotic. And if it is a low-risk person or a patient, you might continue the same antibiotic for some time or change to oral group of antibiotic like as I described, ciprofloxacin plus augmentin, and discharge the patient. But if the patient is a high-risk category, as I described with the score of less than 21, you can continue the same antibiotic for a period which will make the patient adequately covered with antibiotic, meaning thereby that the patient is afebrile for a period of 2 to 3 days, and the antibiotics have been given for a period of at least 5 days. And then there are certain situations where you have to be very particular. you have to decide whether I must treat this patient, remove the catheter, etc. And the important source of infection in these patients of neutropenia is the intravascular catheter associated infections. And the important pointer as far as microbiology is concerned, that you have to get a differential time period to decide whether the catheter is infected or not. Because as we know, having a catheter in place is also an important thing in these patients. You have to have the catheter, so just removal of the catheter at the slightest suspicion is not accepted, or it is not useful to you in your practice, and therefore you have to do the culture. And if you get a growth in the blood which is withdrawn from the catheter tip, and the growth which is taken from the peripheral blood, and the peripheral blood growth is coming 2 hours after the catheter growth, that would give an indication that the catheter is the source of infection which demands its removal. And so these are the various indications. The most commonly which I feel and use in my practice is that when the patient gets repeated spikes of fever, chills, and fall of BP when I flush the line. That is what one of the important factor which I say. And a febrile patient, when I want to use his line and after use I want to flush it with hep log, the patient gets fever and chills and maybe fall of blood pressure. That is the pointer towards catheter associated infection which demands catheter's removal. Then there are all types of infections we have to think of, like coming from the lungs, where you have to consider various viruses like respiratory syncytial or influenza viruses. Many times to diagnose the lung infections, you don't have to be shy of going ahead with the invasive procedures, even in neutropenic patients, because that might change the etiology of that fever, and that probably would give the completely different diagnosis where the agents could be viruses and the treatment would be antiviral rather than antibacterial. So you might be required to do the procedures like bronchoalveolar lavage. The duration of antibiotic therapy, as I said already, that you have to cover it for adequate period so that the patient is afebrile for a period of around 2 to 3 days, and antibiotics have been given for a period of 5 to 7 days at least. When we are required to add fungal agents. So now a patient is having prolonged fever, you are given and tried antibiotics including the 3rd generation, 4th generation cephalosporins or carbapenems, you have added aminoglycosides, vancomycin, fever is still ongoing, patient is crossing the limit of 5 to 7 days, and still patient is not responding to his fever. And that is the time when probably it is to add the antifungal agent. And how do we add antifungal agents? Those can be added in such patients with the various strategies like prophylaxis, where you are giving the antifungal agents it is a very broad spectrum approach to prevent fungal infections, like administration of fluconazole. The presently recommended drug is posaconazole. The second approach is empirical antifungal therapy, that the fever is not lasting for 7 days and more, is not becoming afebrile, you are adding antifungal. That is empirical therapy. Preemptive therapy is that when you are seeing certain signs and symptoms which could suggest fungal infections, certain tests like galactomannan are coming positive, certain CT findings are there which are suggestive of fungal infections, you want to prevent the development of full-blown fungal infection, you are giving antifungal agents. And lastly, which is not most of the time possible, is therapy for diagnosed invasive fungal infection. And what are the potential options for empirical antifungal agents in patients with febrile neutropenia? The classical and the gold standard is indeed amphotericin B, but very, very toxic. The smoother variety of amphotericin, but a costlier one which is in market, is liposomal amphotericin B. Itraconazole is the one which is not in good vogue. Caspofungin and voriconazole and the new development of availability of posaconazole are added to great to our armamentarium of dealing with the fungal infections. So this is the preemptive antifungal therapy, and this is the picture where you are probably likely to add amphotericin to this patient, or voriconazole, which has now become a drug of choice, to addition. And what is this? This is a classical halo sign which suggests that the patient is having aspergillosis infection. And aspergillosis on CT scan is diagnosed with this particular finding where you are seeing an halo. I am unable to show the pointer, but you can see that here you can see the halo-like picture, and in the crescent sign where you can see that there is some dark crescent-like area over that dense area, that is because of the neutrophils coming up is liquefying that area, leading to the development of crescent sign. These signs on CT scan suggest aspergillosis, and voriconazole is the drug of choice in such situation. And it is not only always the aspergillus is the infection which is in these patients. You can get infections like zygomycetes which are resistant to voriconazole. And the CT classical finding, which is very recently described, is called as reverse halo sign, where you can see a dense periphery and a relatively less dense center. which go in favor of zygomycetes. So halocine for aspergillus and reverse halocine for zygomycetes, which doesn't respond to voriconazole, but which responds to the combination of amphotericin and caspofungin. And this is an assay which is available to diagnose invasive fungal infection called as galactomannan assay. And these are the various pathogens out of which we all as physicians are aware of only Candida. But let me tell you that Candida species is going down as far as classical Candida which we know of is Candida albicans, and which is susceptible to the fluconazole. All other Candidas are resistant to fluconazole, which are increasing in number, and therefore you have to use another azoles, which include drugs like voriconazole or posaconazole for treatment of these patients. Aspergillus is one of the dreaded infections, as I said earlier, that it can lead to development of acute respiratory failure and patient can die. Zygomycetes is another differential where the treatment would be with caspofungin plus liposomal amphotericin, and voriconazole is a drug of choice for treatment of invasive aspergillus infection. No more it is the amphotericin B. Posaconazole is a new drug which is having a very broad spectrum activity against all types of fungi, including zygomycetes, and is a drug of choice for prophylaxis in chemotherapy of patients of acute myeloid leukemias and hematopoietic stem cell transplantation. Last but not the least, this is the last slide. I must say that colony stimulating factor have come to our help in a great way in the management of febrile neutropenia. It deals with the neutropenic part, and in a patient whose bone marrow is fairly functioning, colony stimulating factors like GCSF, granulocyte colony stimulating factor, or GMCSF help us to a great extent in mobilizing the neutrophils from the bone marrow into circulation to fight the infection, and they are very well used with very good benefit. And they should be considered in patients with fever and neutropenia to help you out of that dreaded situation. So a combination of powerful antibiotics, antifungals, and growth factors probably can salvage this situation in the management of a dreaded condition like febrile neutropenia. Thank you very much. Thank you, Ram.
Thank you, sir. I would request Dr. P.P. Joshi, sir, and Dr. H.S. Vora, sir, to felicitate Dr. Avinash Fofri, sir, with memento and floral bouquet. I would also request Dr. P.P. Joshi, sir, and Dr. H.S. Vora, sir, to felicitate Dr. S.M. Patil, sir, with memento and floral bouquet.
I think we are still running short of time, and would you allow us to have a couple of questions from the audience, the organizers?
Anyone who want to ask question,
I think we'll have it at the end again. Yes. So yes, so save the time. And next speaker, we have another specialist from Nagpur. He's the only HIV specialist from Nagpur, and may I request Dr. Milind Bruchundi. He'll speak on FEO in immunocompromised host.
First of all, I thank the organizers of Vapicon, Dr. T.C. Rathod, Dr. Agrawal, Dr. Bora, for giving me this opportunity to come in front of you and share my experience. Yes, we have already heard to the stalwarts in medicine, Dr. S.M. Patil and Dr. Avinash Fofri regarding the FEO. I am going to restrict my talk only to the HIV. My disclosures are, I have been helped by a lot of people, and basically my patients who has been through the ordeal of investigations. FUO traditional definition has already been covered by Dr. S.M. Patil. I just want to have this imagination, that's imagine, if you want to just sum up the infections, medications, autoimmune disorders, granulomatous conditions, idiopathic, neoplasia, endocrine disorders. Here in HIV, autoimmune disorders will not be there because there is no immunity already. So there will be no manifestation of autoimmune disorders. Otherwise, all the imagines are there. We know that is commonly the patients with HIV infection, they are accompanied by significant morbidity and mortality. And in 30% of the patients, FUO is one of the main presenting symptoms of HIV. So, is there a separate definition for HIV FUO? Yes, there is definitely a definition. This particular definition has already been covered by Dr. S.M. Patil. But on the top of it, if you think of HIV specifically, then the BIVA guidelines have given us in 2009 that you should have the microbiological cultures, that is a must, and the other investigations include the cultures of blood and urine. That is the must to say that the patient is having FUO. If these cultures are negative, then only you are going to say FUO in HIV. So HIV associated with the FUO, the infections and malignancies are most common. Autoimmune disorders, connective tissue disorders, they are rarely in these patients. And if they are there, then usually they are there after the iris. Because in autoimmune disorders, you have to have a good immunity. You start the patient on ART, and that time these autoimmune disorders will come up. And the important thing is, always the infections are categorized as on the basis of CD4. So it's just diagnosis in HIV of FUO is a puzzle. You should have a basic demography, you should have a history, a proper history, you should go in for a literature review, you should always have a second opinion. The serology in HIV is usually not there to help you, but the cultures and biopsy results, always try to get the fluid as well as always try to get a tissue. If these two things are there in your mind, in most of the time in FUO you will be able to reach the diagnosis. So what are the conditions that occur at any CD4? TB, TB and TB. Bacterial pneumonias, UTI, sinusitis, salmonella and intra-abdominal, intrahepatic as well as other hidden abscesses. Parasites at any CD4, malaria. We usually miss malaria in HIV most of the times. Then there are viral infections, malignancies, and drug reactions, very important because TMPSMX, that is a cyclin DS or cotrimoxazole, is used rampantly in HIV. Many a times that might be the cause of the fever. If the CD4 count is less, then PCP pneumonias, Kaposi sarcomania, though not common in India, lymphomas. If the CD4 count is less than 100, cryptococcomas, toxoplasma, histoplasma, and the MACs, and CD4 less than 50, you should have in suspicion of a CMV or a MAC. This is a series in US where I have worked, and during that time, the 37% of the patients with FUO in that situation also had tuberculosis. The other ones were CMV, PCPs, etc. But again, in US also, the Mycobacterium tuberculosis as well as the MAC, they predominate the causes of FUOs. So do not miss the common treatable conditions. So always this is a dictum in HIV also, which is dictum in the non-HIV patients in FUO. But here also we have to see to it that usually we miss the common infections and we go for the very uncommon infections. So there is an algorithm. It is basically dependent on the symptomatology. After doing the basic investigation, what are the system which is involved, and according to that system we investigate the patient in HIV. So if, for example, cardiovascular, respiratory there, 2D echo, as Dr. Patil sir has stated, endocarditis is missed in many patients. So that has to be done in the HIV positive also. So there's a thing like FUO that's atypical of typicality. So there are typical manifestations of infection, common infection as you get in FUO. In non-HIV, you can have a typical manifestations of uncommon infections. But in HIV, if you consider, it is always the atypical manifestations of a common infection and atypical manifestation of an uncommon infection. And here also, I'll say again tuberculosis. And the way the tuberculosis present in HIV is really mind-boggling. You cannot, I had a patient who had a very huge ulcer type of bed sore type of thing, had a lot of antibiotics given by various different physicians. Cultures were done, but nobody has done the brush biopsy, which was showing AFB. Patient was put on anti-TB and patient responded. So CSF yield as well as the sputum yield is very low. if the patient is having pulmonary tuberculosis, 60% of the patient will not have sputum A/B positive. That is the problem with the DOTS and HIV, because they are basically believing only on the sputum. So I will say here, the X-ray test is must in all the patients if you are suspecting tuberculosis. Just on the basis of sputum negativity in DOT centers, you should not say that patient doesn't have tuberculosis. Even if you talk of CSA field, again CSA field is also very low, and the ZN stain may provide you the evidence of tuberculosis. I again repeat that it may provide you, but in many of the situations, X-ray test will be normal, no sputum examination findings will be there, but typical fever, and without that you don't have any other things. WHO has recommended empirical anti-tuberculosis treatment in HIV only, not in other patients, and it is a diagnostic trial of 15 days. If patient respond in HIV to the anti-TB drug which is given empirically, then that is taken as the diagnosis of tuberculosis. So you can have a normal presentation of tuberculosis, you can have an abnormal presentation of tuberculosis, you can have extensive lymphadenopathies, you can have abdominal lymphadenopathy. This is a very typical thing. Most of the patients who are referred to me with fever, they usually are coming with fever and the sonography is not done. They don't have any abdominal symptoms. But I go for USG abdomen, I get multiple lymph nodes with a microabscess in the spleen, definitely suggestive of tuberculosis. You can have other typical presentation also. This patient has come to me, 34-year-old individual. He was detected to be positive. In January 2012, he had PCP pneumonia. He was started on antiretroviral therapy. But again, he came back to me after 2 months, and this thing was reported as a tumor. And we initially, before that, we have gone for a BAL. BAL was negative. We have done the first FNSC, which was not conclusive. Again, we repeated the second, and you know what it was. It was an inflammatory fibroblastic pseudotumor. What is that? I didn't know really. When I searched and asked Dr. Ravi, who's a pathologist, he said this is typical of iris tuberculosis. Immune reconstitution inflammatory syndrome, iris, in tuberculosis can cause this non-necrotizing inflammatory myeloblastic pseudotumor sort of thing. But my patient was already on anti-TB. So whenever you are having any patient coming to you with fever who started fever after 3 weeks to 3 months after initiation of ART, then you should suspect the patient to have iris. And in India, the most common iris is tuberculosis. So how we definition of iris is, after starting ART, if you are having a new infection or an infection which was latent infection or a subclinical infection coming out and presenting itself and causing the deterioration in health of the patient, that is what we call as iris. So whenever we start any patient on ART, we should counsel him that he may have such things. In our own study, Dr. Brushundy and Dr. Pradeep Mishra, we have published this thing in Lancet. We had a lot of patients coming up with the iris as tuberculosis, cryptococcal meningitis, toxoplasma, PCP, CMV, and hepatitis C, as well as PML. So whenever you start a treatment and you get a fever, always try to look out for the iris. So another is pneumocystic pneumonia. You have typical presentations, but atypical presentation of this PCP pneumonia, very common. Normal X-ray chest, only SpO2 is less, nothing else other than that. This patient also has the same thing. And unfortunately for that, this patient was referred from here to there, and ultimately when came to us, he was already patient of HIV positivity, but he only had night sweats. Only night sweats, that was the thing. But when I saw his SpO2, it was 87. X-ray was absolutely normal. Occurs in around 60% of the patients of PCP in initial stage. But when the CT was done, HRCT was done, it was flooded with the ground glass appearance suggestive of PCP pneumonia. So we have treated him, and patient became all right. Cryptococcal meningitis, you know that, everybody knows that cryptococcal meningitis is the way it presents. But cryptococcal meningitis can also be very, very crucial diagnosis in the management of fever, because many of patients will be coming to you with fever, night sweats, and some abnormal behaviors or abnormal hallucinations or like that. In that patient, if the CSF is negative, go for our CRAG. Cryptococcal antigen is CSF is must. In our own study in Lata Mangeshkar, where we have seen 31 patients, you will not believe only 77.4% had a CSF India Inc. Preparation positive. Other were not having CSF India Inc. So that is again an important thing. Toxoplasma. Typical presentations are there, but the atypical presentations are also there. This fellow who was 27-year-old had a history of fever for 4 weeks, and when he had convulsions, he came to us. On CT scan, there was a very doubtful. So here, investigations are there, but whether it is tuberculoma or it's toxoplasma, I cannot say. And the patient's condition was very much bad. Dr. Barokar was there to treat, but he was also saying that, sir, we cannot take a chance. Either it's a cryptococcus, it's a toxoplasma or it's a tuberculoma. So I put him patient on both the things. After slightly becoming better, fever was persistent. Patient's relative opted for going to a Bombay hospital, where they said there is no need of tuberculosis treatment, it's just a toxoplasma.